I'm Dr. Fakir Obadi, and this is hepatitis C virus in adults. Here's a quick introduction to Hep C. The hepatitis C virus was actually discovered in 1989. Prior to 1989, it was actually referred to as non-A, non-B hepatitis because at the time, hepatitis A and B were the only known hepatitis viruses. Hep C is the leading cause of chronic hepatitis, cirrhosis, and liver cancer, which is referred to as hepatocellular carcinoma. Hep C is the primary indication for liver transplantation, and about 60% of transmission occur by injection drug use. Other risk factors for transmission include blood transfusion prior to 1992, high lifetime number of sexual partners, dialysis, and vertical transmission from infected mothers. Now, let's take a look at the prevalence of Hep C worldwide in the US and in California. In this chart, we are looking at the number of infected people in the number of millions on the y-axis, and you will see that about 58 million people worldwide have chronic hepatitis C virus. And when you compare it to some of the other chronic conditions, you will see that there are more people with type 2 diabetes, about 463 million, and hepatitis B much more common, and fewer people have HIV. And when you look at United States, you see similar patterns with type 2 diabetes being more common, with 37 million people estimated, and about 2.4 million people with chronic hepatitis C. And in California specifically, now these numbers are in thousands. You will see that about 320,000 people have chronic hepatitis C compared to 140,000 people with HIV. And importantly, over 400,000 people globally die annually from liver disease caused by hepatitis C. It's important to note that most patients are asymptomatic. So once someone is exposed to Hep C, over a period of 2 to 26 weeks, they will develop acute infections. However, this acute infection will resolve in some patients. About 66 to 82%, however, will go on to develop chronic infection. So if after 6 months, the acute infection has not been naturally resolved, this will develop chronic infections. And about a quarter of these patients will develop cirrhosis over a period of 25 to 30 years. So it's a slowly progressive disease for a minority of patients. Of course, there are a group of people who will accelerate to cirrhosis over a period of 2 to 10 years, so much faster than 2 to 3 decades. And these patients include people who have organ transplant, if they have other infections that will harm the liver, so HIV and hepatitis B, alcohol consumption, and NAFLD, obesity, insulin resistant, older age, and male sex. These are risk factors that will accelerate progression to cirrhosis. And about a quarter of these patients with cirrhosis will go on to develop hepatocellular carcinoma or decompensated liver disease. And of course, this can be deadly without liver transplantation. Now, acute hepatitis C infection is asymptomatic is in the large majority of patients, up to 85% of individuals. And when they do have symptoms, these are pretty mild symptoms, so malaise, jaundice, and influenza-like symptoms, and elevated aminotransferase levels such as ALT and AST. In chronic hepatitis C, again, a lot of patients, in fact, most patients are asymptomatic. ALT levels can typically fluctuate independent of symptoms. Insulin resistance often occurs in chronically infected person. Steatosis is usually present, and specifically in genotype 3. And once the patients get to decompensated cirrhosis, of course, they will have complications of that condition. Some individuals can also display extrahepatic, meaning outside of the liver. So extrahepatic symptoms such as cryoglobulinemia, vasculitis, porphyria cutanea tarda, and membranous glomerulonephritis. Here's how the assessment of liver fibrosis is done in patients with hepatitis C. So essentially the gold standard is histologic staging by liver biopsy. As you can imagine, this is invasive, so you will actually need liver tissue. Although this is gold standard, this is not something that's commonly done nowadays. And with liver biopsy, what you do with from the tissue is that essentially you will get a fibrosis score that ranges from F0 to F4, and from is progressively increased fibrosis from F0 to F3, and at F4 essentially this will be cirrhosis. And there are other risk scores that can be used, but the metavir fibrosis is most commonly used with liver biopsy. But more importantly, we have other non-invasive methods to measure fibrosis. So for example, there is a equation, so FIB4 or fibrosis 4, that you can see here. It has essentially 4 lab values in there. One of them is age, but you can also include in there AST and square root of ALT and number of platelets. And once you calculate this equation, it will give you the likelihood that somebody will have advanced fibrosis. So essentially you can think of it as cirrhosis. So if the FIB4 score is greater than 3.25, there is a 97% specificity for essentially saying that somebody is likely to have cirrhosis, whereas if the FIB4 score is less than 1.45, there's 85% sensitivity. So essentially a large likelihood that the patient does not have cirrhosis. And in between, score between these two numbers are not going to be as helpful. There are also other methods outside of equations. So most commonly we have the FibroScan. So this is essentially ultrasound. So this is the technology is referred to as transient elastography. So essentially we use ultrasound to see how elastic the liver is. So the higher the level of fibrosis, the more rigid the liver tissue is. So based on this FibroScan, you can determine with high accuracy what degree of fibrosis the patient has. And this essentially measures it in kilopascal, so different measurements will translate into metavir score. And of course, the gold standard for classification of cirrhosis is the Child-Turcotte-Pugh classification. So there are different things that go into calculating this score, and there are online calculators that can be used. But more importantly, based on how many points the patients get, they will be classified as Child-Turcotte-Pugh Class A, Class B, or Class C. And what's important here for us is that Class A is compensated cirrhosis, whereas Class B and C are considered decompensated cirrhosis. And that's important because when we choose hepatitis C treatment, treatment is different whether the patient is compensated or decompensated. So it's important to know that Class A is compensated, B and C are decompensated, and of course Class C is worse than Class B. When it comes to screening for Hep C virus, the recommendation used to be that we needed to screen baby boomers. However, because of the opioid crisis that's going on right now, the guidelines have actually changed to recommend that all individuals aged 18 years or older be actually screened one time in their lifetime, as well as people who get pregnant. For every pregnancy, as part of routine prenatal care, patients should be screened for Hep C. Now, annually, people who inject drugs, as well as HIV positive men having sex with men who have unprotected sex, and MSM or men having sex with men who take HIV pre-exposure prophylaxis, they should be screened for Hep C annually. And of course, periodically, all persons with ongoing risk factor for Hep C, and these risk factors are listed for you on the right-hand side. These recommendations from AASLD and IDSA are actually consistent with the 2020 recommendation from the United States Preventive Service Task Force, which recommended all adults aged 18 to 79 years should be screened for Hep C.
Now let's take a look at diagnosis of Hep C. So the least expensive method we have for diagnosis is to have ELISA test for Hep C antibody. So if somebody, if you get the Hep C antibody, and if it's non-reactive, you can actually rule out Hep C. And of course, that is within reason. So it takes time for antibodies to develop. So if somebody had risky behavior in the past couple of weeks, then that's not really a good method of ruling out Hep C. Now, if the antibodies are positive or reactive, then we actually do the more expensive test, which is the RNA PCR. So we actually check for the RNA, and if we do not detect it, it could be due to two reasons. One could be because that was a false positive with the antibody. So if you don't find the RNA, that means the antibody was a false positive, so they don't really have an infection. Or if somebody had infection in the past and either the body cleared it or the patient received treatment, the antibodies will be around, so it will test positive. But if you didn't find the actual RNA, that means they don't have an active infection right now. So that means that once somebody gets Hep C and they get treated, going forward, you should never get the antibody test again, because it will always be positive. So once someone is treated and you're wondering if they have another infection, you should just use the RNA test. And of course, if the RNA test is positive, that means they have current Hep C infection and they should be connected or linked to care to receive treatment.
Now, when you get results back from a Hep C RNA assay, there are three different possibilities. One is that the assay may not detect an RNA, and that could either mean that there is no infection, so that's why it didn't detect it, but also it could be a limitation of the assay. So with current technology, if the viral levels are actually less than 10 to 12, so there might be some virus in circulation, but the assay may not be able to detect it. So that's referred to as the lower limit of detection, and that's with current technology about 10 to 12. And then you might be able to detect it and not be able to quantify it. So you might see the results say detected, Hep C RNA detected, but less than 25, or quantity unknown. That means that the assay detected the virus, it just couldn't tell you the concentration, what was the quantity in international unit per ml. Or if the viral load is large enough, it could say that it detected the RNA and it would actually give you a level. So it will quantify what that level was. And that's typically if it's more than 25 international units per ml, most assays with current technology are able to actually quantify.
So now let's take a look at some definitions. So here on the x-axis we're looking at time, and the y-axis we're looking at the viral level increasing in basically in logs. So every increment is a 1 log increase. So going from 1,000 to 10,000 is a 1 log increase. So let's say somebody has Hep C, so their viral level is at some levels, let's say 1 million. So somebody's viral level is 1 million. So at some point we would like to start treatment in this patient. So let's say the viral load is 1 million and we start treatment. And treatment for Hep C, unlike HIV, is not forever. So it's just for a duration, because we can actually cure Hep C. So we can actually clear the virus out of the system. So after a while, we will end treatment. So this will be your duration of therapy. So whether it's 8 weeks of treatment or 12 weeks of treatment or 24 weeks of treatment, at some point it will be the end of treatment. So what we would like to see is, once you start treatment, you want the viral levels to drop. You want it to continue to drop while on treatment and become undetectable. So here's your level of detection. So during treatment, while the patient is taking drugs, you want it to become undetectable. And then at some point, you stop treatment, because we do not need to treat forever. So what we would like to see after you stop treatment is for the viral level to remain undetectable as time goes on. And if the level continues to stay undetectable, we call this a response, or this person was a responder. So they responded to treatment. So the question is, how long, should we check to see if the levels remained undetectable, or how long should we check? So the gold standard is to wait 12 weeks after the end of treatment. So it turns out if just because we can't really detect zero, so at the end of treatment it might be, for example, 5. So it turns out 12 weeks is enough time. So if there's any virus left, for it to become detectable again after you stop treatment. So by definition, we wait 12 weeks after the end of the treatment, and then we check the viral load. And if it's undetectable after 12 weeks, we call this a cure, or a sustained virologic response, or SVR12. So SVR12 means sustained virologic response 12 weeks after the end of treatment. So that's our primary endpoint. So in clinical trials, they actually look for SVR12. So whatever new drug they bring to the market, once they stop treatment, they wait 12 weeks, and then they get a viral load. If it's undetectable, they call it a cure, because it's extremely unlikely that beyond 12 weeks become detectable. Another thing that can happen once you start treatment is for the levels to become undetectable while the patient is on treatment, and then when you stop treatment, then the viral becomes detectable again, and that's typically happens before 12 weeks, and we call this a relapse. So at week 12, after the end of treatment, if you check and you actually get detectable viral load, we say that this patient had a relapse, so you need to treat them again. The first learning objective is describe the hepatitis C virus life cycle and the mechanism of action of direct-acting antiviral agents. Now let's take a look at the virus itself. So the hep C virus is actually an envelope positive sense single-stranded RNA. So you can see here that so there's an envelope outside of the virus, and then within the virus there's the single-stranded RNA, which is surrounded by a nucleocapsid. And I'll explain what positive sense means in a minute. So the virus primarily affects the hepatocyte, or the liver cells. And what it does is that, it's a single-stranded RNA. It's ready to be translated. So positive sense means that it's ready to go find the ribosome and translate the genetic material into protein. So the final product, once it goes to the host cell, is a polyprotein. And this polyprotein actually includes 10 polypeptides. And these 10 polypeptides have important role in the life cycle of the hep C virus. So these 10 polypeptides, 3 of them are referred to as structural proteins. So there are core proteins that make up the nucleocapsid. And also there are 2 envelope glycoproteins, E1 and E2. So you can see E1 and E2 are in the envelope that have, and they have a role in attachment to the hepatocyte. And the remaining 7 peptides are non-structural proteins. So NS stands for non-structural. And each of these have a role. Now, because the hep C actually the replication lacks proofreading, there will be a lot of variation. So every time it replicates, there will be mutations, and these mutations add up over time, and it has led to different genotypes. So in generally speaking, we have 7 major genotypes, and within each genotype there's up to 30% variation. So up to 30% variation will still be within a genotype. And then each genotype can also have subtypes. So the subtypes will be denoted by letters A. So for example, genotype 1 can have genotype 1 subtype 1A, 1B, and so forth. So in the United States, genotype 1 actually constitutes 75% of the cases, and the remaining 25% are genotype 2 and 3. So the remaining, so genotype 4, 5, 6, and 7 are not very common. So I'm actually not going to talk about genotype 4, 5, 6, and 7. So this is in the United States. So if you get a patient with hep C who's coming from outside of the US, you should suspect other genotypes, especially from Asia. Like in the Middle East, genotype 4 is common, and other genotypes are common in Russia and Central Asia. Let's take a look at the life cycle of hep C. So I'm going to orient you to this picture. So we're basically looking at a single cell in the liver or a hepatocyte. So you can see the purple area is the nucleus, and then surrounding the nucleus is the endoplasmic reticulum. And this is of course a rough endoplasmic reticulum because there are ribosomes that are attached. And then in the green structures are the Golgi apparatus. And then you can see the surrounding hepatocytes. So let's take a look at the steps in the hep C life cycle. So step one is actually attachment to the hepatocyte. So one of the primary reasons that hep C affects hepatocyte is that it needs to be associated with lipid particles like LDLs and VLDLs, and that's actually where LDLs and VLDLs are generated in the liver. So that's why because the virus needs to be associated with LDLs in order to attach to a cell, it primarily affects the hepatocytes. So once it gets attached and goes inside the cell, the viral RNA will be released into the host cell. And as I mentioned before, it's a positive sense RNA, meaning that it doesn't really need to do anything other than to find a ribosome and translate its genetic material into protein. And that's exactly what it does. So the hep C RNA will find a ribosome and will translate into a polyprotein, which includes 10 individual peptides in a single long polyprotein. So as I mentioned, each one of these polypeptides has a function. However, in order for them to do their function, they need to be processed. So these need to be cleaved into individual peptides. So the host proteases actually will process the first few peptides. The remaining peptides are actually processed by hep C's own proteases. So NS2 is a protease, and NS3 and 4A are proteases. So NS3 and 4A together will actually process the remaining peptides. And we actually target this with drugs. So we have a class of drugs referred to as NS3, NS4A protease inhibitors. So by blocking the enzymatic activity of NS3 and NS4A, the virus will not be able to process the remaining peptides, and because the remaining peptides have an important function for the life cycle of the hep C, that will interrupt the life cycle. Now, once those peptides are processed, they actually remain in the membrane of the endoplasmic reticulum, and they will be rearranged, and which is initiated what NS5A. So one of these is NS5A. So we'll rearrange them and form a membranous web inside the membrane of the endoplasmic reticulum. And this membranous web is important because inside of the membranous web is where the new RNA will be replicated. And we actually can target this with a class of drugs referred to as NS5A inhibitors. So because NS5A will arrange this membranous web, we can actually block it. So we have NS5A inhibitors. And once you have all these proteins inside the membranous web, the first thing that the virus does is that it actually makes a complementary replica of the RNA. So it will actually make a negative sense RNA. And then that negative sense RNA will serve as a template, and then the polymerase, which is NS5B. NS5B is the RNA polymerase that will make complementary replicas of the hep C RNA. So the end products are actually positive sense RNA. So the end result will be the actual genetic material for new viruses. And because NS5B is the RNA polymerase for the hep C, we actually targeted with a class of drugs referred to as NS5B polymerase inhibitors. Another thing that NS5A does, besides forming the membranous web, is that it actually has a role in virion assembly. So once all these new RNAs are produced, they need to be assembled into a new virus. So again, this happens in association with lipid particles like LDLs and VLDLs. So really, when we have NS5A inhibitors, it really has two mechanisms of action. So it will block virion assembly, and it will also block formation of membranous web. And of course, the final step is for this virion to go through the Golgi apparatus and through exocytosis be released out of the hepatocyte, and then the cycle continues. So then it can attach to the next hepatocyte and continue the replication. So that's how it replicates. Let's take a look at how it actually causes damage to the liver. So while all this replication is happening, which predominantly happens in the hepatocytes, a lot of inflammation will happen. So the immune system will actually, try to clear the virus. So there will be inflammation involved. So one of the things that the body does is try to basically kill the affected hepatocytes. And there are also a lot of cytokines. So the ongoing inflammation will cause damage to the liver. Now, one problem is because the virus mutates very quickly, the immune system is unable to completely clear it in a lot of individuals. So that's why the virus persists, and the immune system will not be able to clear it, but the ongoing inflammation will cause fibrosis to the hepatic tissue, and over time, this fibrosis of hepatic tissue will lead to cirrhosis. One reason that the Hep C virus can evade the immune system is because of the lack of proofreading. So it mutates so quickly that antibodies that are made by the body cannot really recognize it once it gets mutated.
Yeah, these are the 10 proteins that result from the Hep C genome. Only 3 of them are targeted by drugs. So we have NS5B inhibitors, and we only have one agent that's on the market. So NS5B inhibitors, sofosbuvir, and these end with buvir. We used to have other agents on the market that have been discontinued. Next, we have NS5A inhibitors, and these end as asvir, so ledipasvir, elbasvir, velpatasvir, and pibrentasvir. And we have NS3, NS5A inhibitors, so these are the protease inhibitors that end with previr, so gorazoprevir, voxilaprevir, and galecaprevir.